Hi, guys. Thank you so much for joining us today. We're talking about the ketamine debate for status epilepticus. Here with me are Gabe, Renad, and Caroline, and I'm Salia Farrokh. I'm excited to ask some questions. We're going to start with Gabe. Hi, Gabe. How are you doing?
Oh, well, after that trouncing of a loss, a full 17% voted for me. I'm a little hurt right now, but I think I can power through it.
Okay. So your side of the debate was that do not use ketamine in status epilepticus, correct? Okay.
That was my side, yes.
Okay. So I am going to kind of flip and switch kind of roles here and ask. I know that you had a very good conversation and actually a very strong, I think, story about why we shouldn't use ketamine. But if you had this very specific patient population that you would identify that could possibly benefit very much so from ketamine and status, how would you describe that group? What is that, kind of very clear patient population that you would think, you know what, this is it. This is like a perfect patient for ketamine, and I'm just going to use it despite the shortage.
Yeah, no, it's an excellent question. And I think there are sort of three time points in the treatment of status epilepticus where I really consider the use of ketamine. I think in the majority of patients, if they're moving towards intubation, pairing it with another anesthetic like propofol, for instance, and using both as part of that peri-intubation phase, then there's very little, if any, evidence to support that. But I do think really early ketamine may help mitigate some of the longer-term status epilepticus. I think the other patient where I consider it early are those patients who are hemodynamically unstable. Despite describing cardiovascular collapse, Caroline did an excellent job showing that this phenomenon is really in patients receiving conventional anesthetics like midazolam and propofol along with ketamine. So it's nearly impossible to discern which of these is contributing to that. It's good to be mindful of it, but in those patients who are hemodynamically unstable, I think putting them on ketamine or adding ketamine to their current profile, and Caroline and her colleagues showed that their mean arterial pressure will increase over time, over the course of 5 to 7 days, and their pressor requirements will decrease. Later on, in status epilepticus, those patients who you presume or have diagnosed PRIS, that is a patient that I'm trying to get off propofol almost immediately and rapidly up titrate ketamine if they're not already on it. And so I think those are three of the areas where I really consider ketamine.
Okay, great. Caroline, your turn. So you were talking about how ketamine is amazing and is the magic bullet and everyone should be on it. But I want to flip roles here and ask, is there a specific patient population that if this discussion happened on rounds, you're going to say, absolutely not. This patient will not benefit from ketamine. And if anything, they may actually this may harm them. They may, have some really significant complications from ketamine.
The one patient population that I can think of is patients who are already having like hyperchloremic metabolic acidosis and they're like in shock. I think in that patient population, I would be careful starting ketamine. I would recommend not starting it because of like the diluent that is in like hydrochloride, and you can potentially worsen these patients' metabolic acidosis. So I think in that patient population, from the side effect perspective, I would recommend not choosing ketamine.
Would you be okay if your team said, well, we're just going to bolus with, very concentrated? Is that just the metabolic part of it with the dilution? Or do you think that the drug itself, it's safe if we're just using the high, concentration boluses?
Whether you're using like diluted or undiluted, I think you're going to run into this problem because the diluted one is like in 0.9% sodium chloride. It's a high chloride load. Undiluted one is like hydrochloride as a diluent. So you're going to also have like your hyperchloremic load. So I think like either or you're going to end up facing that. And I've seen cases of like severe cardiovascular collapse with high doses of midazolam and ketamine where they are having like this very high hyperchloremic metabolic acidosis. So in these situations, I'd rather like just down titrate anesthetics as soon as possible to prevent the cardiovascular collapse.
Okay, cool. All right, Renad, I have a question for you that I think was also asked after the talk, but I'm still interested to know what you think about this. There's this whole notion of early and super early, and I think that, Gabe and Caroline kind of talked about, oh, maybe it's, after the first agent, we're really rushing to use ketamine as before even like other anesthetics, or you started before your first anesthetic. But I have a hard time mechanistically thinking about early and super early, meaning, this whole receptor down regulation, up regulation is probably already started, right? So even if we talk about after how many medications in that sequence of, okay, like after your first benzo, that's the time, or even during the time that you're bolusing your midaz, you should bolus your ketamine. Is that really still early? Like, what is the timeline that we're looking at? I know in the pediatric, study that you mentioned, you said 3 days was in one of the studies, right? That was kind of early, and then after that, it was considered late. So I feel like there's a huge discrepancy, and I feel like I still really don't understand if even like we should talk about hours, minutes, or we should talk about, oh, it's probably already too late by the time that we diagnose the patient, right? What do you think about that? What's your kind of assessment and experience?
So I think your question has a couple of different parts. I think the first thing I would address is, while we talked about the receptor trafficking hypothesis, and Caroline did a wonderful job talking about that, there's another hypothesis most of us know about, but I don't think we talk about a lot, and that's 80 to 90% of the receptors in the brain are actually excitatory. And so when you think of status epilepticus and the glutamate overload, it makes sense even early on to target, that receptor group with medications. And so from that perspective, mechanistically, it makes sense to start ketamine. I wouldn't go as far as to say start it instead of a benzo, because that is our standard of care. But again, it's thinking about, okay, well, we use other ASMs that target glutamate and glutamate receptors and excitatory receptors second with non-benzo ASMs like phenytoin. Why not? Is that something that we need to think about? And there actually are centers. I think there's one in Italy where there's talk about using ketamine boluses kind of after that initial load of a benzo, or right after the first line non-benzo ASM as a bolus. And again, is that considered early? Is like you mentioned, is using ketamine as an infusion as your first anesthetic, is that considered early? I think it's really more of a discussion of at least in my experience, what clinicians are comfortable with, right? And so if you have clinicians that are maybe not comfortable using ketamine in general, it might be a bit of a stretch to suggest that we do a bolus, right? Instead of, or right after the first non-benzo ASM. But that is something that in my experience, I've done a couple of times when I can, when I can get the kind of go to do that. And it, in our population, if we are trying to, mitigate the potential for intubation, I think it would be helpful. But even starting it as your first anesthetic, I mean, at that point, the consistent thing that we see in the literature is that treatment delays are there, right? Regardless of whether you're talking about the first non-benzo ASM or the first anesthetic. And it's interesting because we all know that treatment delay is one of the independent factors that leads to poor outcomes, whether in peds or adults. So why aren't we treating patients in general more aggressively? Whether that includes ketamine or not, I think is a discussion. But to be honest, I don't think the debate should be whether or not ketamine is considered a valid option in these patients. I think really what we need to study and what we need to figure out is when and how are we going to use it. That's the area that I would like to see more literature in.
Cool. Thank you, guys. With that, we're ending our session today and hope that you enjoyed the rest of the meeting. Thank you.